So coming to the next question of NEET 2025 cardiology. Again, we have to read from the last line. Which of the following investigation can pick up the etiology in this case? Again, it's a case scenario. We have to understand the case scenario, decide the diagnosis and decide the treatment. A patient presents with sudden onset aphasia and right-sided arm weakness for the past 4 hours. He has a past history of rheumatic heart disease with severe mitral stenosis. So, seems a simple and straightforward one. Sudden onset aphasia and right-sided arm weakness. Whenever something is sudden in neurology, it is a cerebrovascular accident or a stroke. Whenever something is sudden in neurology, it is CVA or stroke. So we are having a case of stroke with the right monoparesis plus aphasia. They have not given what type of aphasia, but we are having a right monoparesis plus aphasia. Usually right monoparesis or a right hemiparesis and aphasia go together because usually the left side of the brain is the dominant brain and the language centers, that is Broca's area and Wernicke's area. Broca's area is area 22, Wernicke's area is area 44. Broca's area is the area for speech or the motor component of the speech or the fluency of speech. Wernicke's area or area 44 is the area for comprehension. Broca's area is located in the frontal lobe. Wernicke's area is located in the parietal lobe. So Wernicke's area is located in the parietal lobe, area 44. Broca's area is located in the frontal lobe, area 22. Wernicke's area is for comprehension of speech. Broca's area is for fluency of speech. Please remember, these two areas are located in the dominant hemisphere of the brain. Okay, these two areas located in the dominant hemisphere of the brain. For most people, the left side is the dominant hemisphere of the brain. So when there is a stroke in the left side, automatically it causes right-sided hemiparesis or monoparesis. That is why these two go together. So this patient is having a right-sided monoparesis plus aphasia, which means he is having an infarct or a hemorrhage, that is a stroke of the left side of the brain involving one of these two areas, right? So it is clearly a stroke. Even if you don't understand the location, you need not know the location in this case because the diagnosis is clear, it's a stroke. And there is a past history of rheumatic heart disease with severe mitral stenosis. So this is a clue regarding the etiology in this case. So etiology of stroke is classified basically into two. We have ischemic stroke and hemorrhagic stroke. Ischemic stroke is of two types: embolic, thrombotic. Of these three, embolic stroke is the most common type of stroke. Embolic stroke is the most common type of stroke. So what type of stroke this patient may have? They have given a clue: rheumatic heart disease with mitral stenosis. In the last question we discussed, atrial fibrillation is of two types. We have valvular AF and non-valvular AF. Valvular AF, we must give anticoagulation because the chance of clot formation and formation of a stroke is very high, right? So this patient is having rheumatic heart disease, so he may have a valvular AF and he may have an embolic stroke. So the probable diagnosis in this case is a valvular AF with atrial fibrillation causing an embolic stroke. Now the question will become very simple. What is the investigation to pick up cardioembolic stroke? Carotid and vertebral Doppler. This Doppler will help us to locate clots or any stenosis in the carotid and vertebral vessels. This will pick up thrombosis. So this is an investigation for thrombotic stroke. Transesophageal echo, of course, it has a role in rheumatic heart disease to pick up clots in the left appendage or left atrium. So this seems inappropriate. In NEET, always read all options before coming to the conclusion. Transthoracic echo. Transthoracic echo is the echo we commonly come across. The echo probe is placed across the chest. Okay, this is also important, but when there is a comparison between transthoracic echo and transesophageal echo, transthoracic echo may miss some left atrial clots, which is picked up by transesophageal echo. So this may be done, but it is not so appropriate when compared to transesophageal echo. So we will exclude this option. MRA brain. Of course, MRA brain is the diagnosis of choice or investigation of choice to pick up stroke. Whatever be the type of stroke, ischemic stroke or hemorrhagic stroke, MRA is the investigation of choice. Especially when the onset of stroke is less than 6 hours, MRA brain is good because it can find out early in fact. But if someone asks the question in NEET, what is the initial investigation of choice, the better answer will be CT brain. Because guidelines say we do not need MRA to decide on treatment of stroke. Basically, if you do a CT brain and it shows an infarct, or to be more precise, if it does not show a hemorrhage, we can treat it as an ischemic stroke. That is what guidelines say. Plus, MRA brain is time consuming, it takes around 1 hour, whereas CT brain is a rapid test, it takes only 5 hours. So when the patient comes in the window period of stroke, which is less than, when the patient comes in the window period of stroke, which is less than the 4.5 hours of time limit, you should not waste time because time is brain. In that case, the initial investigation of choice is obviously CT brain. Suppose CT brain does not pick up an infarct and you have completed the treatment and the patient has crossed the window of 4.5 hours. In that case, MRA may be preferred again to correctly diagnose ischemic stroke. Right? So understand the question whether it is initial investigation of choice or the investigation of choice and look at the time intervals before answering this question. So this patient is 4 hours. He comes under the window period of stroke. So MRA brain is not so ideal. CT brain is ideal, not to waste time. So, but still MRA brain is an option. So now the thing is we have to decide between whether MRA brain is the answer or transesophageal echo is the answer. Read the question, which of the following investigation can pick up the etiology of this case? MRA brain finds out the diagnosis, it is stroke or not, whereas transesophageal echo finds out the etiology, which is embolic stroke. So TE will be the better option here. So please remember in NEET every word is important, right? So you can read the question 2 times. They have asked the etiology, which investigation picks up the etiology of this case, right? So TE will be the answer. Now, how will you manage this case? So we didn't discuss this in the last case. We discussed about the rate control options and we discussed about the cardioversion rhythm control options of AF. Now what about the anticoagulation? As already discussed, anticoagulation in atrial fibrillation should be done for any case of valvular atrial fibrillation to prevent cardioembolic stroke. Next, it should be done in non-valvular AF when the CHA2DS score is 2 or more. CHA2DS score is 2 or more than 2 and can be given when there is an RST with previous history of stroke that is ischemic stroke. The side effect of anticoagulation is hemorrhage. So when there is a previous history of hemorrhagic stroke, this is contraindicated. And patients who are taking anticoagulation for ischemic stroke may develop a complication of hemorrhagic stroke. So that can also be given as a scenario. So please be careful. What are the options available for anticoagulation? Again, we have a category called VKA. vitamin K antagonist. If you have to remember one name here of vitamin K antagonist, remember warfarin. Okay, warfarin is very important in pharmacology because it has so many drug interactions, it has so many protein binding. So we can discuss that in pharmacology. And the other option is Novac or Dovac. That is new oral anticoagulants or directly acting oral anticoagulants. Why the term directly acting oral anticoagulant? When you come to the pathway of coagulation, you would have heard about the terms extrinsic pathway, intrinsic pathway of coagulation, and both merge into the common pathway, that is factor 10. So whether coagulation gets activated by extrinsic pathway or intrinsic pathway, it finally ends into factor 10, where factor 10 gets converted to activated factor 10. This converts factor 7 to activated factor 7, and this converts factor 2 to activated factor 2. Factor 2 is prothrombin. So even if you don't remember the other factor names, just remember factor 2, it is prothrombin, gets converted to thrombin. So Dovac is directly acting oral anticoagulants. These category of drugs directly inhibit factor 10A, whereas vitamin K antagonists, they inhibit vitamin K. You would have known the vitamin K dependent clotting factors, factors 2, 7, 9 and 10. These are the vitamin K dependent clotting factors. So vitamin K does not inhibit factor 10 or factor 7 or factor 2 directly. Vitamin K antagonists inhibit vitamin K, hence these vitamin K dependent clotting factors are not produced, hence clotting does not happen. Whereas the category Novac or Dovac directly inhibits the factor 10. So what are the drugs which are available? Apixaban, rivaroxaban, edoxaban, and another drug is dabigatran. Even if you get confused with the name in the exam, just see the clue here, XA. XA is nothing but 10A, activated factor 10A. So this apixaban, rivaroxaban, edoxaban all have XA in their name. So these three drugs inhibit factor 10A. They directly inhibit 10A. Dabigatran is also a directly acting oral anticoagulant. Again, see from the name, it is TRAN. TR is thrombin antagonist. Right, so dabigatran inhibits thrombin. Thrombin is factor 2. Right, so the directly acting oral anticoagulants may be factor 10A inhibitors or factor 2A inhibitors. Factor 10A inhibitors comes with the name XA, apixaban, rivaroxaban, edoxaban, and factor 2A inhibitors or thrombin inhibitors or direct thrombin inhibitors comes with the name TRAN, dabigatran. Okay, so these are the options for anticoagulation, and this completes the discussion of this case.